Hey, welcome back. We're continuing on in the Continence module, looking at the lecture series in section 2. We're on page 14 in the module. So what we're going to do now is overlook, we've gone through what is normal voiding physiology. We need to have an intact brain, pons, spinal cord system that communicates with the organs or the bladder and the pelvic floor or the sphincter mechanism. The brain is the social continence mechanism. This tells when it's socially appropriate to void. The pons is a coordination between the spinal cord and the brain, and then the spinal cord. And based on different aspects of the spinal cord and the nerves that are coming off, we have autonomic and sensory motor fibers that help control the storage and emptying of the bladder. At rest, the bladder is filling. The pelvic floor is controlled by the sympathetic nervous system, and the bladder is controlled by the sympathetic nervous system. The S in sympathetic stands for storage, and the urine is dripping from the kidneys through the ureter into the bladder. When the bladder gets to a critical point that sends a message to the brain and says, "Hey, brain, I'm full. Find a socially appropriate spot for me to empty," the continent person will go to the toilet, and at the right mechanism, the bladder will squeeze because the parasympathetic nervous system is enacted, or it PEEs, P-E-E for parasympathetic, and the pelvic floor relaxes and opens. So the bladder relaxing is juxtapositioned with the pelvic floor contracting. That maintains continence. When the bladder contracts, the pelvic floor needs to relax and open. So based on this nervous system, we have drugs that actually enact on these organs to mimic the nervous system. Sympathomimetic drugs mimic storage. Alpha adrenergic drugs mimic storage also because the receptors in the urethra, which are alpha receptors, actually contract. Alpha blocking receptors relax the urethra and the alpha receptors. Estrogen receptors help the coaptation of the urethra, and cholinergic medications, although not used extensively, actually help the bladder contract, whereas anticholinergics help the bladder relax. So hopefully that was a good refresher of what we just went over. Now, part of my questioning for you as students, as we're looking at this information, how does this apply to being a nurse, a wound ostomy continence nurse, and how does it apply to being a continence nurse, the thing that I really want you to consider? So when you think of our patient population and what works normally, you have to have a normal intact brain functioning. You have to have a normal intact spinal cord, specifically the S2 to S4, and specifically the T6 to lumbar region. We need to have an intact pudendal nerve, an intact muscle in the pelvic floor. Things need to be supported and lifted into place. So if any of these mechanisms are out of whack, we have the potential for incontinence. And so I hope that as you look at this and think of your patient population, think, have you ever asked, are you having problems with incontinence? I'm sure you've had people who've had brain traumas or things going on that don't work in their brain, and that could have an impact. So that was my quick review. Once again, if you have any questions, please feel free to contact one of the instructor clinicians here at the WOCNEC, and we will help you sort of figure this all out, because sometimes when you don't use it or think about it, it can be a little confusing. So now we're going to go on in the continence module to section 2, and let's look at the abnormal. What can we do about this? So this is Issues and Classifications, section 2, page 14. Our goal for this section is to look through the objectives and discuss the impact of urinary incontinence on the individual, family, and healthcare system. And then what can we do as continence nurses to impact our society? We're going to look at the reversible factors and then the chronic pathologies and risk factors that make somebody incontinent. So this will be in a couple of different sections. If you have Hopefully, as you go through, you might be watching more videos. So let's start off. Urinary incontinence, the reversible factors, and management is what we're going to talk about first. So I always like to use a little humor when we're talking about that. This is one of the signs in a bathroom. Our aim is to keep the bathroom clean. Gentlemen, your aim will help. Stand close is shorter than you think. And ladies, please remain seated for the entire performance. So what is the prevalence and significance of incontinence in our society? Recent studies have shown that 53% of community-dwelling elderly, or 47 to 70% of institutionalized people, have incontinence issues. And actually, this is one of the major reasons people are placed into long-term care, is because of incontinence issues. But these numbers are also likely underreported. Incontinence still has a social stigma. People don't talk about it. We're not asked about it in our follow-up appointments, and people just assume, unless you can smell it, that people are continent. When we know that it's underreported because we look at the industry. Costs greater than $12 billion annually are spent on continence products, and this has a huge impact on somebody's self-esteem and their social activities. I've had patients who come into my office and just wept because all they wanted to do is be able to go grocery shopping, but were not able to make it out of their home because they were wet all the time. The problem with incontinence also is that it doesn't really have a medical problem in the sense that you don't die from it. If somebody has a heart problem, they will definitely check with their surgeon. If they're having a stroke, there's a lot of impact. And in the US, we quite frankly don't even talk about it. And so there's this link between incontinence and other problems, such as falls, people sliding when they're getting up in the middle of the night, people who have secondary yeast and maceration injuries, people have chronic urinary tract infections because they're not voiding adequately or successfully. So who's to help these people? We, the nurses. This is an excellent opportunity for us to get to the bottom of the problem, no pun intended, and really help patients. Not only is it rewarding because instantly you have gratification because you see a change, and there's a lot of things that we can do that are very minimal and helping our patients improve. So as a WOC nurse who's not an APRN, what can you do? On page 16 and 17, the WOCN has, in 2009, delineated some of the responsibilities as a continence nurse and what we can do. Part of it is a focused assessment, reviewing medications, doing bedside testing, and just making sure that people are aware that continence is an important aspect of caring for the whole patient, not just the whole of the patient. We want to look at interventions. We can do behavioral management, look at medications, and help discuss side effects and delineate treatment plans that will reduce the side effect. We can also give instruction on clean intermittent catheterization, be aware of different products that are available, and make recommendations on that. We also have that wonderful opportunity to look at diet and fluid modifications that can overall impact the patient. Now, if you're as excited about continence as I am, you may decide that this is a career you'd like to pursue. As an advanced practice nurse, not only was I able to do those things, but I could also delineate a much more complex plan, prescribe medications, and look after this very needy patient population who is actually quite underserved in this country. We also get to do important diagnostic interpretation and test ordering, and we'll talk about that a little bit more in the future. But even if you choose that continence is one aspect of the care that you're providing as a WOC nurse, please don't underestimate the power that you have in changing somebody's life for the better. So, when we're looking at urinary incontinence, how do we delineate it? Fortunately, there's a transient versus established route. A transient is factors that affect continence at a particular time. These typically are a sudden urge or worsening symptoms, but it's not long-term incontinence once these are reversed. If you think of college students, a lot of times they will experience an episode of incontinence after a heavy night of drinking. It's not because they're incontinent, it's because the alcohol affected their brain and bladder communication system, and they were not able to find a socially appropriate spot to empty it. It may have been in the bushes or on themselves. Once the alcohol was out of the system, they were able to regain their continence. So that's just a little example of what transient or acute incontinence is. Usually these factors can be cured, and once we address those, the incontinence is resolved. Then we have the people who have chronic or long-standing incontinence. This is established incontinence, and what happens is, despite addressing those factors, the incontinence is not resolved, and they usually have a specific pattern or probable cause and contributing factors that need to be addressed in more detail. So what we're going to do first is look at the etiology of acute transient factors. So this is my helpful hint from Heloise. In your learning exercises that you'll be doing, there's 4, Mrs. A, Mr. B, Mrs. C, and Mrs. I. These 4 exercises you'll be doing, they're not a graded mark, but a complete, satisfactory, or incomplete. What our goal is to help you look at the transient factors in different scenarios and address those transient factors. So when you're handing in these assignments, please make sure that you look at all the diapers, D-I-A-P-P-E-R-S, and we're going to talk about what that means. These are the acute incontinence episodes. A lot of times when we address these factors, reverse the transient factors, their incontinence will go away. That doesn't mean that they don't need other factors addressed also, but for every patient who presents with avoiding dysfunction or incontinence problem, you want to address these factors. That leads me to another question. What is the difference between incontinence and avoiding dysfunction? Avoiding dysfunction may or may be without leakage. You may not be able to get to the toilet in time, or you may be able to get to the toilet in time, but it's just very frequent and very urgent. Whereas incontinence is defined as leakage in your underwear in a socially inappropriate time. So please be aware, as another trick, that sometimes a patient might have avoiding dysfunction but actually not be incontinent. You may still address the transient factors because their urgency, frequency, or other problem could be addressed and alleviated. Typically, avoiding dysfunction is something that's happening that's troublesome to the patient. Let's talk about this in more detail. So what does diapers stand for? Each of these letters will help you remember what the reversible factors are. In your module are the standard reversible factors, but I've added some in this lecture just to help have a more global look at the patient. Remember that the ones in the module during the main part of the module are the things that you'll be tested on. The other information is to help augment your clinical practice and just make you a better nurse overall. So the first one is don't sleep and delirium. So what is delirium? Delirium is the loss of ability to accurately interpret and respond to your bodily signals. It may be caused by infection, electrolyte imbalance, or pharmaceuticals. So this is the type of patient who may be on a bolus of morphine and due to the sedation effects of the drug are not able to actually interpret the message of have to go to the toilet in a timely manner. It could also be somebody who has a urinary tract infection and is not competent to get to the toilet in time. Delirium is reversible. The patient who has dementia, it is not reversible. Delirium is an acute episode due to some other factor. So as I said, infection, sedating narcotics, something like that. You want to make sure that if somebody has delirium and dementia, that you're able to tease out which is which. So how do you manage this? You want to look at the etiology and the contributing factors. Is somebody delirious because they've just moved into a new residents and actually don't know where the toilets are, and they're getting confused of how to get to the bathroom or out of their bedroom? Is it due to the fact that somebody has a superimposed urinary tract infection and they're elderly and the presenting factor is confusion? Also under D is don't sleep or nautria. Nautria is a complaint that an individual is getting up one or more times at night to void. It's a troublesome complaint. Nautria can be because of polyuria at night. This is when you make greater than 20 to 30% of your total 24-hour voided volume during the nighttime hours. How would you know that? By looking at the voiding diary. This way we can tease out when the person is drinking and when they're making urine. Some of the ways that you can screen a patient's desire for treatment is look at their lifestyle. When are they taking fluid? What type of fluid are they taking? And what type of diuretics are they taking? That's a kind of a tricky question. Why do we talk about pharmacology in the voiding pill? Lasix, L-A-S-I-X, was named that because its pharmacological action, it lasts 6 hours. So when we think of our patient population who's on a diuretic, many times they take the diuretic first thing in the morning. If it lasts 6 hours, if they take it at 8 a.m., it's out of their system by 2. Then what happens? So that patient, because they're peeing all morning, will stay at home and limit their activities so that they're close to a toilet. Then at 2 o'clock, when their diuresis has actually subsided, they go out grocery shopping, go play cards with their friends, go and have social functions. During that time, they're accumulating lower extremity edema, which mobilizes as the diuretics out of their system. When they get home and fix their evening meal, they may sit down, but then typically they go to bed with a large amount of fluid on their lower extremities. Then, as they're lying in the horizontal position, that fluid is mobilized to their kidneys and they diurese throughout the evening. So a lot of times those patients are diuresing all night. When they wake up in the morning, their lower extremity edema has subsided, but they take the diuretic anyhow. When you consider the action of a diuretic, that combined with somebody's lifestyle, we can do the timing of the diuretic to actually improve their episodes of nautria. When you wake up in the morning, you have lower extremity edema is at a minimum because you've been in a horizontal position all night. So instead of taking your diuretic in the early morning, it would be best to take it in the afternoon, say 2 o'clock in the afternoon. During the morning, they do their grocery shopping, their card games, socializing, and all that time their fluid is accumulating in their lower extremities. If they take their diuretic at 2, they have a 6-hour window between 2 and 8 p.m. to diurese. In the afternoon, if they're home and diuresing instead of out gallivanting, the fluid is mobilized and they have less lower extremity edema. So when they go to bed that evening at 10 o'clock, they've only had 2 hours of fluid accumulation, and actually they won't have as much nautria. This is one of the things that you can do as a continence nurse that does not require extensive training, but just to look at the MAR and decide as a home health nurse when you're reviewing the meds, are they having problems with nautria? Are they having problems getting up at night? Did they break their hip because they tripped as they were trying to find the toilet in a poorly lit room? So that's one way that you can help with don't sleep. The other one that's quite reversible is sleep apnea. Many people who snore or have sleep apnea have also increased frequency, urgency, and nautria at night. The reason is the negative pressure that's elicited in the chest cavity because of the occluded obstructive sleep apnea actually triggers the heart to suppress the release of antidiuretic hormone. Actually, this would cause the person to diurese during the evening or while they're sleeping, and hence they will have more nautria and more frequency and urgency at night. This combined with being tired from sleeping can actually be quite hazardous to the patient. Having a sleep study or referring the patient back to their primary care physician to evaluate their sleep apnea can actually change their overall output for nautria. I had one patient who was getting up 14 times in an 8-hour period of sleep. He was absolutely exhausted. When I asked him if he snored, his wife elbowed him and said, "Of course he does. He sounds like a freight train." We sent him off to sleep apnea studies. He got his CPAP, and his nausea actually decreased to 4 times a night. Personally, that would be way too much for me, but for him, he was getting much needed rest and was feeling much more refreshed and able to cope, not only with his job during the day, but also with his family responsibilities because he was rested. The next one is infection or irritants. When you think of the bladder, it's at rest. It's just hanging out, and it needs to not contract as it's filling up. If there's something in the bladder, an irritant or an infection, that can actually tickle the detrusor muscle and cause it to contract when it's not actually full. Some of the irritants and infections that can cause this are due to bacterial growth. Infections are commonly gram-positive bacteria or enterococcus, or gram-negative bacteria, which are E. coli, enterobacter species like Klebsiella, protease, and Pseudomonas. When you think of the anatomy of the male and female, the rectum has a straight shot for the bacteria that are living very well in the rectum, not causing any problem, to run straight along the perineum into the urethra. The male's urethra is long enough that the bacteria typically does not climb it and get into the bladder and cause a problem. But with the straight shot of the female urethra, the bacteria can go straight up and cause a bladder infection. So our goal is to keep the bacteria out. So how do we decide if somebody has a urinary tract infection? First of all, are they symptomatic? Symptomatic is a fever of greater than 100.5, flank or pelvic pain, abdominal distension, dysuria, dyspareunia, altered mental status, or just pain in general. Increased frequency or urgency is also accompanying a UTI. They also may have malodorous urine and suprapubic pain. The issue is a lot of women, as they age, can actually have asymptomatic bacteremia. When you check their culture, they actually have bacteria but do not have those signs and symptoms. So it's imperative that we look and see if they're symptomatic and not just treat the culture based on the microbial growth. So how do you culture? You want to do a formal dipstick, a formal UA, urinalysis, where you send the urine to a lab to be evaluated. There's some reliability and specificity problems with the dipsticks if they're not stored correctly. You also want to send for a formal culture and sensitivity to ensure that you're treating the bacteria that are actually causing the problem. You look at susceptibilities in a colony count of greater than 10 to the 5 per milliliter. The other problem that the I stands for is irritants. Irritants are substances that, when in contact with the detrusor muscle, actually cause the bladder to contract. We have an extensive list here that I've made, the C list. The reason I chose C is to help you remember each of the factors. Coffee and tea, even when it's decaffeinated, can actually cause bladder irritation. Cold remedies, cranberry, vitamin C, chocolate, carbonation, colas or Coke. When I say that, those are brown colored drinks. Citrus, whether fresh juice or concentrate. Chardonnay or Corona, and that's for alcohol. It's not just white wine and beer. Crystal Light, meaning artificial sweeteners. Candies and other sugar substitutes. Chili and other substances such as spicy tomatoes, honey and artificial sweeteners. And finally, cigarette smoking. When you look at this list, I kind of wonder how many people actually are able to go to the toilet and not have a dysfunction or incontinence. But as each of us are created different, this list may or may not be a problem for certain people. When you're looking at the bladder diary, you want to look at this list and evaluate whether or not these fluids actually caused irritation. A lot of times we'll have patients remove all of the factors and then reintroduce them one at a time for a 1-week period and see if their symptoms resume or regress. A lot of times people don't realize what they're putting in their mouth can actually have an impact on their bladder. Remember, the kidneys filter out all the irritants, and the garbage that's left in the bladder is what can be irritating. So when we're doing a look at irritants, you also want to look at the fluid management. Is the patient taking an adequate amount of fluid for their size and shape? Ideally, 30 cc's per kg per day of water is necessary to remain hydrated. The goal is to keep the irritants in the bladder in an aqueous solution so it doesn't knock on that detrusor muscle and cause it to be irritated. The goal is to have pale yellow urine that is not concentrated and doesn't have an odor. So sensory urgency, or the desire to go, actually increases when you're taking irritants, and that can be translated as a feeling of a full bladder when it's actually not full at all. So this actually contributes to overactive bladder and sometimes can contribute to just general feelings of urgency and frequency. One of the things that you want to do as a mechanism to help these patients is to limit fluids after 6 p.m. A lot of times patients will want to continue drinking up to when they go to bed and even after that because of dry cotton mouth. So you want to talk to patients about different strategies to decrease the dry mouth as well as providing enough fluid intake. Some people also refuse to take fluid in because they think that if they dehydrate themselves, they won't leak as much, which in reality is a possibility, but not always the best thing. Atrophic vaginitis. Growing old is not persistence. When you think of the normal vaginal environment, we need normal bacteria there that actually keeps the vagina healthy and retards the transportation of bacteria from the anal area to the urethral area to be able to protect the skin against infection. So these bacteria are actually called lactobacillus bacteria, and they keep the vaginal mucosa in an acidic environment. Isn't it incredible that we've talked about acid throughout this course, and our body is an acid environment. We want our skin to be at low pH. We want our urine to be a low pH. And actually our vagina is a pH of approximately the same as vinegar. If the skin around the vagina becomes alkaline, that is an environment that's actually much more favorable for the migration of bacteria. And therefore, a way of maintaining this acidic environment is maintaining the amount of estrogen. The lactobacilli thrive in an estrogen-rich environment. But as we get older, women actually have estrogen stores that are decreased. Remember that estrogen not only causes the urethra to be coacting or closing, but it also keeps the tissue of the vagina healthy. So how does this present for a patient? They have pale pink mucosa, loss of rugae, petechial hemorrhages, carbuncles, a neutral pH when tested, and finally a shift in vaginal flora to colonic bacteria. So when you're actually checking the vagina, you will find some of those bacteria that we talked about causing UTIs in the vaginal mucosa. So if you look at this diagram here, we have a picture of the patient who has the normal estrogen and then somebody with estrogen deficiency. So you see with the normal estrogen, positive rugae, so it's nice bumpy ridges in the vagina that shows that it's healthy. It's a nice vibrant pink color throughout. The urethra is a little, is within the labial folds. It's not protrudent and it's not recessed. The labia majora, which we can't see on this picture, are actually like a full tire. They're nice and plump and extending from the pubic symphysis all the way down to the posterior part of the introitus. The labia minora also extend to this area. They're free floating and can be easily moved. As a person with estrogen deficiency presents, you can see in the right-hand picture, first of all, they have a carbuncle. What happens is the urethral tissue is seeking out estrogen and will actually become quite vascular and looks like a cherry pop. They will have Their labia majora and minora actually look like a deflated tire. They will have fusing of the labia minora, meaning that instead of being able to separate it and see two distinct tissue margins, it will actually be fused together. And when you separate it, they can actually have fissures and a lot of pain. The introitus is, can be actually less fluid. It will be, it can actually be scarred, and it can have very pale to white tissue. The vaginal mucosa actually has an absence of petechial ridges. Of rugae ridges. Here's a live patient that you can see the differences. So here we see the fusing of the labia minora and the labia majora. You can't see the delineation, and it actually, the labia minora stops right here. And it all looks like it's one actual tissue now. You also see the vaginal bulb is very smooth and pale, and also the hood on the clitoris is fused down. This is another patient, and this is the speculum right here. You can see how pale and smooth the mucosa is, and there's petechial hedges. It looks like somebody hemorrhages. It looks like somebody took a Sharpie pen and just did polka dots. This patient also has fused labia minora, and you can see the plumpness of the labia majora has actually decreased. Both of these patients are indications of urogenital atrophy. Why is this important? Well, a lot of these patients present with vaginal burning, watery vaginal discharge, vaginal dryness, uncomfortable during intercourse or dyspareunia, and vaginal or vulvar itching. That's what's happening in the vulvovaginal region, and that translates into bladder problems with recurrent bladder infections, urgency frequency, nautria, dysuria, and plus or minus incontinence. So when you think of this patient presenting, what else do they sound like? Right, topical candidiasis. A lot of times you'll have watery discharge, things will be very uncomfortable down there, and especially if the patient has dementia, they'll be itching. Think of the nursing home patients, who these ladies with their long fingers are down there grabbing. Why? Because they actually have itching, burning, and dryness. Typically, what do we actually treat these patients for? Exactly, with diflucan for topical candidiasis. How many of us or our providers are actually looking at their perineums? That's the question. A lot of times we're throwing antifungals at these patients, and their symptoms don't resolve because that's not the problem. They may have a fungal infection superimposed onto atrophic vaginitis, but a lot of times their symptoms will not be resolved until the atrophic vaginitis or the underlying problem is addressed. So the North American Menopause Position Statement talked to women about taking estrogen by mouth and topically. After the studies have come out, there's a lot of people who are concerned about taking oral estrogens and concerned whether or not they can actually take it. So the estrogen that we're proposing here is actually topical. In your module, if you turn to page 148 in the appendix, this is appendix 1, the guidelines and dosing for administration of topical estrogen. Estrogen comes in 3 delivery systems: an E-string, which is a silicone ring impregnated with estrogen that's placed in the vaginal vault and changed every 3 months. People can still be sexually active, and it's a time-released estrogen formulation. Estrace and Premarin are both topical creams that can either be put on the fingertip and applied into the vaginal introitus and wiped up onto the labia minora majora. This is actually, they have a loading dose of approximately 2 to 3 weeks, and then have intermittent therapies. Vagifem is a small pill that is placed in the vaginal vault, and it dissolves and releases estrogen on the tissues. On page 149, this is one of the fingertip application methods. Estrogen therapies are expensive, and a lot of people don't want to use it. They come with an applicator that you can use, but if you have dexterity issues or a really fluffy abdomen, it's very difficult to get to the tissue that needs treating. If you compare the distance on a female from her final phalangeal joint to the tip, it's actually basically all the same. If you apply the estrogen to this area, along here, that's approximately 2 grams. The finger's placed in the vaginal vault and wiped up. They don't have to manipulate the plunger and have the sheets and everything else treated. This is much easier, and women are much more adherent to the plan of care if they have less things to mess with. Length of treatment is very important, and as a continence nurse, reiterating this with patients is important. You want to discuss with them that it's generally 4 to 12 weeks to actually have benefit. Loss of estrogen stores has gone on for a long period of time, but typically it's not realized until a year later. So 4 to 12 weeks of therapy is necessary for resolution of symptoms, and continued therapy once initiation is necessary to decide whether or not they're having good results. A lot of times women will talk to their primary care provider about whether or not they actually want to have estrogen therapy. It's contraindicated for the woman who has had estrogen-sensitive cancers, for example, ovarian or breast cancer. As continence nurses, it's not our decision to make that choice, but we can actually refer them back to their oncologist or primary care doctor to decide whether or not the risks and benefits of topical estrogen would be beneficial. The next thing we're going to talk about is pharmaceuticals. Many drugs can actually contribute to the loss of continence through their effect on urine production, sensory experiences, and smoother skeletal muscle function. So when we look at this list of drugs, we have different drugs that can actually increase your frequency, urgency, and polyuria. We talked a little bit about natriuretic and diuretics, but caffeine and alcohol also has this effect. Many people know the effect of the beer at the bar. Stress urinary incontinence is actually affected by alpha-adrenergic antagonists. So when you think about it, if you've got an alpha drug, those alpha receptors, if you antagonize it, it will actually relax the pelvic floor and keep it open instead of coacting. Urinary retention, or the inability for the bladder to completely empty, can be affected by anticholinergics. Remember, they're affecting the cholinergic receptors and not contracting the bladder. Alpha-adrenergic agonists, beta-adrenergic agonists, calcium channel blockers, antipsychotics, and narcotics. So all these medications, when we're reviewing our medication list, could have some effect on our ability to empty. When you think of anticholinergics, it's not just for bladders anymore. Anticholinergics are also in antidiarrheal medicines and antispasmodics. They're being used for people who have Parkinson's disease. Also, you think of the medications like SSNRIs for depression, and those can actually cause retention also. So when we're looking at the whole patient and their medical record, you know that some of those medications can work together and cause them to have more problems. So as a continence nurse, it's important to look at these lists and ask our patients if they've had any problems since initiating some of these medications, because a simple change in medication or dosing or timing structure could actually impair or impede their function to go. I put this slide in for medications just to be aware of what's available over the counter. A lot of times we encourage patients to use lubricants for different things, such as catheterizing, such as for painful intercourse, for lubricating the perineum. I learned this the hard way. As you can see in this Publix aisle, we have a row here of personal lubricants. These are all water-based lubricants. I said to my patient, and use the brand name, KY Jelly. I said you can also get the generic. When she went to the clinic, I taught her in the clinic how to CIC. She was able to do it without any difficulty, and I sent her home and asked her to come back for a follow-up appointment. When she came back, she was quite distraught and told me that she did not want to do it. It burned, it was terrible, it was horrible, awful, all mad. So I asked her to show me what she was doing at home. She dumped her bag, and there she had the KY Jelly. When I looked at it and further noted that it was KY Touch. This is actually the warming cinnamon flavored jelly. It's for intercourse, not for CIC. When I asked her why she chose that KY Jelly, she informed me that it was much more expensive than the other lubricants, and so since it was expensive, she knew for sure that it must work better. Unfortunately, I was not aware of the other lubricants that were available so readily, and now have chosen to teach my patients that more money does not mean better necessarily. Also, you'll note here is Astroglide, which is a silicone-based lubricant. These you need to be aware of when using with different products that are placed in the bladder or vagina, as they can denigrate the plastics used for catheters. Psychological issues. Factors such as severe depression may alter an individual's ability to motivate or motivation to actually go to the toilet. When you consider our patient population, 19 million Americans suffer from depression annually. That's 9.5% of the population. So when you consider out of the 100 patients that you may see this week, 9 of them may have incontinence. That's 1 out of 20 individuals over the age of 12. Excuse me. They may have depression, not incontinence. And out of those people, a lot of them may also have incontinence. So what came first, the depression or the incontinence? It's sort of one of those vicious cycles. I'm really depressed because I keep wetting my pants, and my social circles are getting smaller and smaller and smaller, and therefore they continue to have problems. One of the things that I recommend is consider evaluating your patients if you have any indication that they may be depressed. The Patient Health Questionnaire, the PHQ-9, is one of those quick, easy, 9-point questionnaires that you can ask on a scale of 0 to 3 to evaluate if a patient is having problems with depression. Excuse me. If they do have problems with depression, you want to make sure that you refer them to a mental health specialist in your community or back to their primary care doctor so that that can be addressed and their incontinence hopefully will be resolved at the same time. Endocrine issues or excess urine production. This can be as a result of medication or endocrine issues or excess fluid intake. When you consider endocrine issues, weight loss decreases the weekly incontinence episodes of 47% in the treatment group to 28% in the control group. This was statistically important for stress incontinence, not urge incontinence. So just the fact of losing weight can actually improve how much our bladders leak. Then we want to think of the metabolic conditions and constipation that can affect incontinence. When you consider that the bladder is followed by the vagina in the female and the rectum, and the bladder is a very irritable neighbor. It just wants to be left alone. All it does is relax or contract. It relaxes and fills or contracts when it's full and empty. But if something's in the vagina or in the uterus pushing on the bladder, it will continually contract when it's not necessarily full. For example, if you think of a woman during pregnancy, she has to void much more frequently because that baby is poking on the bladder and displacing it and causing an irritable message. So a lot of times this resolves after pregnancy. Right next door is the rectum. So if the rectal bowl is full of stool, it can be knocking on the bladder and causing the bladder to respond irritably. When we think of the conditions that would predispose somebody to this, these are a majority of our patient population's underlying conditions. diabetes mellitus. The increase of sugar in the bladder can also cause it to be irritated, and also the diabetes can affect the nerve fibers communicating to the bladder for contraction and relaxation. Hypothyroidism, hyperkalemia, hypokalemia, hypomagnesia, and heavy metal poisoning all impact the bladder's ability to store and empty. The next one is restricted mobility and retention. Restricted mobility is the increased time it requires for an individual to make it to a toilet after they have received the message. So, what could cause restricted mobility? Well, considering the adult who's aging, it could be due to the fact that their legs don't quite work as quickly as they did before. They might have physical obstructions on the way to the toilet, a series of stairs, slippery floors, a toilet that's actually quite low and they're fearful of falling, so they're very slow and deliberate in their movements to go to the bathroom. Restricted mobility can also be secondary to dexterity issues. I've had many patients who put multiple layers of clothing on to be fashionably forward, but at the same time it actually impedes their ability to disrobe when they need to go to the toilet. For example, it's a lot harder to unzip and unbutton multiple closures than it is to pull down elastic-waisted clothes. Ladies, especially in Charleston, I've noted have multiple layers of undergarments to be all smooth and not have wrinkles. These undergarments include girdles, control top pantyhose, Spanx, slits, and underblouses. This can all slow down the time that it takes to actually remove your garment to sit on the toilet and go correctly. When you think of somebody who has restricted mobility in terms of a recently broken limb or the removal of a limb from a traumatic accident, being able to toilet may be more of a difficult situation than previously noted. Retention is when the water can't go out. This is a reversible factor. Sometimes it's due to an underlying factor, or it might be something that is just for a brief point in time. For example, somebody who's had benign prostatic hypertrophy, by managing it with medication, the urine can get out. And hopefully all of our patients will be like Alex here and be able to water the bushes. Stool issues or stool impaction. Once again, let's remember where the bladder is in recognition of the intestine. Not only is the bladder completely surrounded by intestine, but all of that intestine can actually impede the ability of the bladder to relax and contract efficiently. Scientists in Bristol, England, home and birthplace of my father and Cary Grant, devised the Bristol Stool Form Scale. This is a 7-point scale that studies all the different types of stool that people usually have. This is between number 1 and number 7. If you look in your appendices, it's on page 213 and 214. This is an excellent way for you to articulate and be able to standardize stool production of a patient. Number 1 is separate hard lumps like nuts that are difficult to pass. And number 7 is watery, no solid pieces, entirely liquid stool. Not only is this an excellent way for people who are preoccupied with their stool to be able to tell you exactly what it looks like, but it's also an excellent way to help children self-regulate their eating habits to get the stool that is actually a goal of a number 4. The goal to have a bowel movement is to be able to sit on the toilet and evacuate one's bowels completely without the need to strain or to push. I'll share an example. During Bridge Week, one of our students' children were left at home with their dad, and as a mechanism to help be more efficient while mom was away at school, they decided to get school lunches. The 5-year-old, who is already vegetable-phobic, had decided that he was not going to eat any of the fruit because it was too mushy on the lunch trays. So during the course of the 5 days that Mom was away, he ate no fruits and vegetables. And when she returned on the weekend, found him in the bathroom grunting and groaning, trying to have a bowel movement. So she produced the Bristol Stool Form Scale and said to him, "You have control over this. By drinking, exercising, and eating fruits and vegetables, you can actually get a number 4, and that's the goal." So her son took this, as any 5-year-old boy would do, with great gusto, and actually ate his green beans for dinner and was quite thrilled when he had a number 4 the next morning. Not to be outdone, his 7-year-old sister got in on the act. She also was eating her vegetables and fruit, and each morning the two of them were comparing their stools. Unbeknownst to Dad, until the morning that the two of them were standing outside the bathroom door, and as he emerged, they yelled, "What number were you, Dad? What number?" So I take it with great pride that I'm actually giving these problems of stool formation to future generations. The American Gastroenterological Association actually has a position paper that looks at how do we handle constipation and stool impaction. For somebody who has normal transit constipation, the first line of offense is fiber and milk and magnesia. If they improve, continuing this regimen or adding Dulcolax if there's no improvement. And you can continue to upgrade the different types of lactulose and other medications to get the desired results. In combination with the Bristol Stool Form Scale and an eating diary, you as a continence nurse can give mechanisms to help patients actually improve the consistency of their stool so that there's not the problem of retained stool in the rectum causing irritation on the bladder. So the take-home message is constipation. It brings the beast out of all of us, and our goal is to look at our medications which are constipating and fiber in our diet to promote good evacuation. This concludes section 1 of section 2. We are now completed up to page 21. We're going to take a break and then start again in a moment. Thank you.